to talk about some stressor agents, the A2A agonists. We're going to talk about reducing radiation with software and hardware, and also the use of stress-only imaging. We're going to talk about advances in gamma camera technology. We're going to talk about radio tracers and applications using other techniques to integrate SPECT and PET with anatomy. So let's start off with physiologic effects of stressors. As you know, when you walk and do anything, your body changes ATP to ADP to AMP to A, which is adenosine, okay? And so physical activity leads to the adenosine production, and adenosine production leads to vasodilation in the peripheral bed. So it's a very nice feedback. So why not just give something that stimulates adenosine receptors? So of course that was done over the years. Diprotamol was the first agent. Adenosine, which is one of the, which is actually the natural agent, was pushed here in terms of using it as a pharmacologic stressor agent. And then, of course, more recently, the A2A agonists, which are semi-selective in that they stimulate the A2A receptor, but have a minimal effect on the A1 receptor, which causes conduction abnormalities, the A2B, which causes peripheral vasodilation and hypotension, and the A3s, which cause bronchoconstriction. So in this regard, these newer agents are important. Regadenoson, as you know, has been out for a couple of years. It was shown in 2 pivotal trials to be comparable to adenosine in terms of detecting the extent of ischemia that was present. Those were the advanced studies, the advanced 1 and the advanced 2. We have also published data looking at quantitative analysis using adenosine compared to regadenoson. And as you can see on this particular slide, you can see this patient has an anterior defect with adenosine. On regadenoson, you see the same thing. This is the rest image, which shows a lot of important redistribution on rest compared to the 2 stressors. And if you look at the quantitative analysis here, you can see that the size of the perfusion defect is virtually identical on adenosine and regadenoson. We published this data in JNC in 2015 showing a very close correlation between perfusion defect size by regadenoson and that by adenosine. So in this regard, not only is regadenoson important in terms of providing the same diagnostic information as adenosine, but also the same prognostic information. The other important issues behind regadenoson are its use in COPD and asthma. There are now many trials out there comparing regadenoson versus placebo, showing no worsening in FEV1 in patients receiving regadenoson versus saline. And in this regard now, dobutamine has been virtually eliminated as a stressor agent in our lab and across the country, where it's only used when patients have first-degree AV block, greater than first-degree AV block, and have no pacemaker. And that's important to remember because remember the clinical trials, even though regadenoson has a very low affinity for the A1 receptor, which causes heart block, it was never studied in patients who had heart block because most of the pivotal trials were adenosine versus regadenoson, and adenosine is contraindicated in anyone with greater than first-degree block. So we do not give it in these kind of patients. That's the only real indication for using dobutamine at this time in nuclear cardiology. The other issue is in end-stage renal disease, and this is important because regadenoson, unlike adenosine, which has less than a 5-second half-life in the coronary bed, regadenoson is actually cleared by the kidneys. So there have actually been several trials over the years looking at people with advanced kidney disease, and even in those who are on dialysis, showing no significant side effects with the use of regadenoson. So in this regard, it is safe in these populations and can be used appropriately in these populations. The other issue is in patients with pulmonary hypertension, because you have a drug that potentially can cause vasodilation and cause a drop in pressure. This could also cause problems in patients with pulmonary hypertension. This is a study that just came out less than a year ago, looking at the use of regadenoson in patients with primary pulmonary hypertension. This is in 67 patients, and the results basically show no serious events with the use of regadenoson. The most common side effects were dyspnea, which is the most common side effect with regadenoson anyway, and there was no ventricular tachycardia, ventricular fibrillation, or second and third degree AV block with the use of regadenoson in this population. So in this population, it works very effectively, and I might also add, it also works very effectively in heart transplant patients, which are it's a contraindication in patients receiving adenosine where they can get significant AV block that is not seen with regadenoson. This is also another important trial, the EXERRT trial. This was published last year, also looking at whether you could simply take patients who perform submaximal exercise and immediately bring down the treadmill speed, and then 3 minutes later inject regadenoson while the patient was still on the treadmill, and whether that would be safe to do, as compared to waiting an hour until until the patient is adequately rested, and then perform regadenoson stress. So if you look at this particular graph, this slide looks at regadenoson versus exercise regadenoson versus rest regadenoson. And you can see no really major differences in terms of heart rate or blood pressure responses with this differences in ways of performing the study. Regadenoson, as we call it, on the fly while the patient is still on the treadmill or waiting an hour later. If you look at secondary endpoints in terms of image quality, actually there was better image quality in patients who were actually getting regadenoson while they were on the treadmill. And this has been shown, generally speaking, with pharmacologic vasodilators where you limit splanchnic blood flow. And so you get better, better target to background ratios and less uptake in the liver, so you get better imaging. And in this particular study, there was also shown to be safe. Now, there were 2 people who actually received regadenoson while on the treadmill and did have cardiac events. One patient had an ACS, and another patient had an MI for a 0.3 event rate. Now, what's interesting about these 2 patients is that they already demonstrated significant ischemia on the treadmill with ST segment depression of like 1 to 2 millimeters, and yet were still given regadenoson. So the moral to that story is that there's no value and potential harm to administer regadenoson to patients who already have ischemia. It makes no sense at all. I mean, if someone's having ischemia on the treadmill and they're submaximal, inject the radiotracer and be done with it. Don't give regadenoson to those kind of patients. Regadenoson is in those who don't have ischemia, where you're trying to identify heterogeneity in coronary blood flow, not cause worsening ischemia, okay? The other thing in terms of the primary endpoint of this study was to actually look at regadenoson exercise versus regadenoson 2 weeks later in terms of perfusion abnormalities versus this 1 hour resting study versus another study again 2 weeks later. And what was shown here was comparability. So there was comparability in terms of the amount of ischemic defects in the 2 protocols in terms of exercise regadenoson on the fly, and then 2 weeks later, a resting regadenoson versus resting regadenoson after an hour, and then 2 weeks later, another resting regadenoson. What was interesting about this study was actually the number of people who actually got worsening ischemia on the second regadenoson stress study, because on the first study, everyone got rest first, followed by regadenoson second. And on the second study, they simply got regadenoson stress. And what this shows is that when you do rest imaging first, you can mask ischemic perfusion defects, okay? Which is one of the reasons why, among other reasons, that in our laboratory, we do stress first to maximize our ability to detect ischemia. This, incidentally, was not the primary endpoint or the secondary endpoint in this study, but it was a very interesting finding in terms of showing that, you could literally mask ischemic perfusion defects if you do a rest injection first, followed by a stressor. And so this clearly needs more evaluation and more investigation, but it's one of the reasons why, stress first imaging is what we routinely use in our laboratory. So I guess we knew that all along. So let's go into stress protocols. I've already talked a little bit about the issue of stress-only imaging. just from the previous study, EXERRT, and there are two major studies showing safety in this using this kind of protocol, and that if you have a normal stress study, you have the same outcome as if you do stress rest imaging. The reason for stress only is significant reduction in radiation exposure. You can get down to 2.5 millisieverts with a 10 millicurie dose, and with a high dose of 25 millicuries, you can get down to 6 millisieverts, so that's pretty good. You conserve technetium, you improve laboratory efficiency, you increase patient satisfaction because they get out of Dodge as soon as they're done with their stress study rather than having to wait and do a rest study. You reduce costs because you eliminate the higher dose of technetium that you ordinarily would give if you did rest stress imaging. And like I said in EXERRT, you may better detect ischemia in patients who undergo stress first imaging followed by rest imaging if needed. The other issue is that we know from these data from Rosansky that positive myocardial perfusion scans has been going down tremendously over the years in terms of the frequency of abnormal studies. I think all of us who read nuclear studies recognize that in terms of the number of normals we see. And so if you look at this study back in 1991, there were about 41% of patients who had an abnormal SPECT and about 30% had ischemia. And you can see now this has markedly been diminished over the years. So another reason to do stress first, because your whole idea is to find out if someone has ischemia and to recognize that most patients will not, that you're really just trying to exclude disease, it makes sense to do stress first rather than rest stress imaging. And again, these are our data showing that stress only versus stress and rest or any kind of rest, stress, rest protocol is just as comparable in terms of overall event rates, with much less in the use of millicuries, so stress only 21 millicuries versus stress rest 55 millicuries. And of course, in this study, over 60% of patients receive less than 5 millisieverts of radiation. So a very effective way in terms of reducing radiation exposure, getting the information you need, and getting out. This has also been shown in terms of technologists, okay? So if you do stress only with a CZT camera versus background stress rest, and that's what was done in this study where they did actually a 12-month period where they did routine imaging, and then the following 12-month period where they actually did stress only with CZT, you can see a marked reduction in radiation exposure to not only our patients, but our technologists in terms of deep dose radiation, shallow dose, and in terms of dose to the lens, like a 50% reduction in radiation exposure. So another good reason to do stress first. And what is also shown in this study is that when you look at the total reduction in radiation exposure, most of that benefit was not with CZT technology. It was because of using stress first and therefore stress only as your imaging protocol. This has now been endorsed by ASNC in multiple publications, including the last guidelines that were just published this past year. And there's a whole section, which I wrote actually, on stress first and stress rest and stress only imaging, who to use it in, what are the limitations, and et cetera, criteria for a normal stress rest study. There are ways in which we can improve our ability to do stress first and stress only imaging. One is to use attenuation correction. This is in a study in patients going pre-bariatric surgery. 89% of these patients had a normal study. Some had a mildly abnormal study. Some had a moderate to severely abnormal study. But what's important in this study is that most of these patients were able to undergo stress-only imaging, even at this very high weight. I mean, these are people with BMIs of 49. Okay, they were still able to undergo only stress imaging because it was normal in most of the patients. And of course, we know that AC correction, whether it be with line sources or with CT, improves our specificity, and particularly in people when you get into very, very high BMIs in terms of being able to determine whether someone's normal or not, because obviously when people are large, you get a lot of attenuation artifacts, and these can be corrected well, especially with CT attenuation. Okay, we can also do this very nicely with prone imaging. And with prone imaging, you don't need any new technology. You just flip someone on their belly and take images. So this is a patient who has an inferior defect on supine stress. This is a patient with no inferior defect on prone imaging. So when you see shifting defects or resolution of defects, you know that's artifacts because real defects don't change with position, okay? So simply by using prone imaging, we can actually improve our ability to do stress-only imaging, and we don't need fancy equipment like SPECT CT or line sources, which we really don't use anymore. It's all CT now. But just shows you how you can get around things and use different methodologies for acquisition that can really improve your ability to identify normal patients. This is a very nice study looking at, a recent study looking at prone imaging and normal stress only. And you can see that if you had a stress only study versus a stress rest, you did just as well in terms of overall survival and also in terms of death NMI over time. And so in the group, in terms of the annualized event rate, it was 1.5% in terms of all events with stress only and comparable with stress rest. This has also been shown in the ED setting in terms of the value of stress-only imaging for getting people in and out of the emergency room or the observation unit. This was published by Dr. Nabi back in 2016, where we randomized people 300 to MPI and 300 to CTA, and about 25% of these patients underwent stress-only imaging. And what we were able to show, basically, is that when you look at time to diagnosis or time to hospital discharge, it was comparable in the CT group versus those who got stress-only. So getting people in and out is very important to us all, and by doing stress first, you can really maximize that ability. We also showed the benefit of nuclear imaging compared to CT, not in the normal group. If you're normal by either technique, you do very, very well. But actually, SPECT was a better predictor of events long-term as compared to an abnormal CTA. And so in terms of sensitivity and negative predictive value, both were very high, 78 to 85%. Over 99% for negative, but in terms of specificity, SPECT was better, positive predictive value was better with SPECT, and overall accuracy was better with SPECT. So we can't just throw the baby out with the bathwater. It's important to remember that with stress-only imaging, we can actually do very effective nuclear imaging in ED patients and get them in and out of the hospital and have very good results in terms of outcomes. Okay, so in terms of stress-only imaging, time to diagnosis was comparable to CT, time to discharge was comparable to CT. Radiation exposure actually was less than CT. Now, this was when we were doing 64-slice CT. So that's not the case probably today. We can get down to, 1 to 5 millisieverts of radiation with CT if it's done in the proper patients. But most centers still use 64-slice CT. That's the bottom line. And if you use 64-slice CT, you're still going to have this kind of higher radiation exposure as compared to stress-only imaging using prone and all these other modalities that we can do to help identify normal patients. Hospital costs in this study were the same. And again, just as Rosansky's study, most people who come in and are evaluated for low and intermediate risk chest pain are going to be normal, over 90% in this study. And so it really behooves us to be able to tell, in a very precise fashion, and that a study is normal and that the patient doesn't need any other further testing. Okay, what about software solutions? Obviously, in everything we do now, instead of using RAM filters, we use iterative reconstruction. That's the same thing with CT, incidentally. CT used to use a ramp filter in terms of doing back projection, but now we do iterative reconstruction to improve our image quality and to get rid of a lot of the noise. And so both in CT and nuclear, this has become an important way of doing things. Also with nuclear, we do this thing called depth-dependent resolution recovery, which is a very important concept. It's just an important concept that the further an object is away from the gamma camera, the more distorted the image. And the closer the object is to the gamma camera head, to the collimator, the more precise the image, the less blurring of the image. So the concept behind this is that the anterior wall is very close to the chest. So you don't have a lot of issues. If you put the gamma camera right on the chest, that's fine. But what about the inferior wall and the posterior wall, which are way deeper within the chest, especially in big people? Well, we can actually correct for that depth-dependent loss in resolution with new software. So between using, and all of this depth-dependent resolution recovery algorithms are all incorporated within iterative reconstruction, so it's all part of the same process. And if you look at comparisons to standard imaging, and this is looking at half dose versus, or half time versus full dose regular or full-time regular imaging, there was always comparability between iterative reconstruction and what you see with standard imaging. And in fact, this is one study that I actually read the studies, the images. Greg Thomas and I read all the images in this particular study from Adahi. We went up to California one afternoon, one day, and we just sat all day reading images on this particular trial. And this looks at the value of full-time half dose versus half-time full dose, okay? And you can see the same kind of results in both sets of images. And this is important because if you have a cooperative patient, you can give half the dose and just have them image for a longer time. But if you have someone who's wiggling all around and won't sit still, you can do half the time but just give full dose. Simple concept, but a very important one, and one you can use with this kind of imaging technique of use. This is using a newer order gamma camera technology. So there are different new gamma camera technologies that are available. There's the Cardius XBO, the Digirad study. That's what that last trial was looking at. There's DSPECT, which is made by Spectrum Dynamics, and there's the GE Discovery, which actually has two newer systems. It's pinhole acquisitions the first time around. Nowadays, they're using a different way of doing the CZT with a rotating gamma camera. But in irrespective, you can markedly reduce your imaging times with the use of these technologies. This is a study by Milena Henslova looking at this compared to conventional imaging. This is doing a rest-stress protocol, 5 millicuries at rest, 15 at stress. You can see very comparable images, whether you use a 5 or 10-minute acquisition here, or a 3 to 5 minute acquisition on the rest studies, and that's compared to a 15-minute acquisition on a traditional gamma camera. So in this study, image quality was very similar between all of these different modalities. This is an interesting study that was published looking at how you might be able to, with a CZT camera, actually determine what your dose should be prior to giving it to the patient. Because we always kind of guesstimate how much millicuries should we give someone, you know, based on their height and weight and this. So this is looking at scan time and image quality. So if you scan people for short amounts of time, you get bad image quality. For long periods of time, you get better image quality. And this is looking at acquired, and obviously that's because the longer you image someone, the higher the counts. And this is looking at acquired counts and image quality. So as you acquire more counts, image quality improves. So what they did is they looked at different parameters in different patients, and they saw basically that as body weight went down, image quality improved. As the amount of mass per kilogram went down, body imaging improved, which none of this is too surprising. If you look at chest circumference, as the chest circumference became less, imaging improved. And as BMI went down, imaging improved. Obviously, high BMIs had bad imaging results. Lower BMIs had very good imaging results. And then they looked at these curves in terms of counts. This is looking at body weight, mass per body weight, kilograms per meter. This is chest circumference. And again, you see that as size increases and body mass increases and chest circumference increases, counts go down for any amount of time that you image. This is also true for BMI. Counts go down considerably. And they actually calculated intrathoracic fat using two different algorithms, Hume and James, which basically takes into consideration lean body mass. And you can see that as lean body mass goes down, as the percent of fat goes up, you can see a reduction in counts. So counts seem to play a very major role. So they came up with this nice little algorithm in terms of tracer dose and effective dose, and what you could do in terms of being able to determine the dose you should give. So they have dose in millibecquerels is 23.8 times the body weight in kilograms divided by the time you image the patient. So just as an example, if someone's a 70-kilogram man, you image for 3 minutes, you need a dose of 15 millicuries. If someone's a 70-kilogram man, you image for 5 minutes, you only need 9 millicuries. And if someone's a 70-kilogram man and you image for 10 minutes, you only need 4.5 millicuries. So you can actually determine, based on these kind of algorithms, how much millicuries you really need for any given amount of body mass, and depending on the time that you image the patient in terms of total imaging. And this is important because we know that radiation is a big issue. We know that dual isotope imaging gives you the highest radiation, about 25 millisieverts. Standard stress only is about 2.5 millisieverts if it's a 10 millicurie dose. Standard stress rest is about 12 millisieverts. Now in Henslova's study, they did 5 rest and 15 stress millicuries, and they got around 6 millisieverts. But you can, if you use 5 millicuries stress only, like I showed in this particular study from Van Dyke, now you can get down to 1 to 2 millisieverts of radiation. So you can see how you can really dramatically drop and tailor your imaging protocol depending on how long you image and the amount of millicuries you give. Okay, and this is important because CT obviously is, although, well, I have to say this less than 1 millisievert nonsense with CT is really kind of nonsense too, because I tell you, our patients aren't less than 1 millisievert unless they're like 100 pounds soaking wet and 5'2". Okay, then they're less than 1 millisievert. Okay, but generally speaking, we don't see people like that. We see people that are 270 pounds and 6'3", and so that's kind of hard to achieve here. But so everything's relative. But we can achieve the lowest radiation exposure by giving low doses of technetium. And I think these data from Van Dyke really help in terms of being able to know what that dose should be depending on the imaging time that you do. Okay, these are some data looking at the value of the prognostic value of 1 millisievert exercise myocardial perfusion scanning. Okay, this is a very interesting study because they took people who had maximal exercise and they had a normal supine or prone image, okay? And they were achieved stress-only imaging. And mean age was 59. You can see, you know, about 70, 80 kilogram weight. A lot of these patients had obviously symptoms for CAD. And the dose here was 3.9 millicuries for the stress dose. Pretty impressive, pretty impressive. And if you look at using two different ways of calculating millisieverts, using the ICRP 60 or the ICRP 103, you can see that irrespective whether you use technetium, sestamivir, or technetium tetraphosphamine, in this study they achieved less than 1 millisievert as a mean dose. So again, a relatively, you know, lightweight population, I mean 79, but, you know, 79 plus or minus 16 kilos, so not too unreasonable. And this is compared to stress rest where, you know, instead of 1 millisievert, it was 4.4 millisieverts. And if you look at outcomes, if you look at major cardiac events or cumulative survival, in this particular population, the cardiac death and non-fatal MI rate was only 0.3% per year, which is really very, very low. And for any event, including revascularization, 0.55% per year. So, and this is using stress only at a very, very low dose, less than 1 millisievert radiation exposure. And incidentally, Andrew Einstein has also published similar data called the millisievert study back in 2014, looking at this same issue. So that's that. Let's talk a little bit about PET imaging. Dr. Al-Mallah has already discussed a lot of this with you before, this whole idea of coronary flow reserve, and the fact that there's really not a very good relationship between the extent of coronary disease and the flow reserve that you see. There's a lot of heterogeneity. And what has been shown over the years, this is very nice data. And you can see that if you have high coronary flow reserve and you have low coronary disease, you do very well. But irrespective of the amount of coronary disease you have, if your coronary flow reserve is low, you do poorly, okay? So that's a very important concept. And in fact, in this particular data set, if you look at people who got revascularized, if they had high coronary flow reserve, and they got no revascularization. They did just as well as people who got bypassed, but in the low that were PCI people with high coronary flow reserve actually did no better than the low coronary group. And I want to, if you look, and you see that over here too, if you look at low coronary flow reserve and no revascularization, you do poorly, but if you get revascularized, you do very, very well. What has also been shown is this disparity between men and women. So it turns out that you're more likely to see abnormal coronary flow reserve in women who have non-obstructive disease than in men who have non-obstructive disease. And that's across the board, unless you get to triple vessel disease. And then, of course, men are more likely to have impaired because they just have more extensive coronary artery disease. What has also been shown is that females, for any degree of abnormality in coronary flow reserve, do worse than men. Maybe that's because they have smaller arteries. Maybe they're more likely to have abnormal capillary blood flow, et cetera. But for whatever reason, they do worse than men. And so women have less obstructive disease, more microvascular disease, and abnormal CRF indicates a worse outcome in women than in men. This is an interesting study in diabetics. If you look at diabetics, okay, so these are patients without CAD, okay, who also have diabetes mellitus, and without CAD who do have diabetes mellitus, okay? And this is looking at coronary flow reserve that's abnormal and coronary flow reserve that's normal. So look at the difference in event rates. It's really pretty staggering. Same population, okay? But just differences in coronary flow reserve in a diabetic population. So we need to learn more about this. We need to learn more about how this filters into our decision making. And if you look at diabetics who have positive coronary disease, that's this group here, they do as bad as the people without coronary disease who have abnormal coronary flow reserve, okay? So again, this is a very important concept in terms of where we stand, in terms of knowing not only whether someone has a perfusion abnormality, but whether someone has abnormal flow reserve in various different beds and the extent to which that happens. And I might also say this also is a very nice way of looking at the issue of diastolic dysfunction. As you know, diastolic dysfunction is really one of the first clinical manifestations of ischemia, okay? And so we know that we can adequately, if we can adequately identify microvascular dysfunction, we might be able to bridge the gap between who are the patients with diastolic dysfunction really have diastolic dysfunction because of microvascular disease or because of other potential pathologic etiologies. And as I said, I think we're just getting into this whole concept of where this all fits together in terms of being able to diagnose people. So, you know, this is one of the things I think once we get our PET program going here, this is something we really need to look at, because the other thing about diastolic dysfunction, and there are data to show this, that if you take an elderly population that's sedentary who have diastolic dysfunction and they start performing regular routine exercise, actually their diastolic dysfunction improves. It gets better. You have less diastolic dysfunction. Why is that? Is that because they have better recruitment of capillary beds? Is that what's the etiology there? But maybe it has a lot to do with improvement in coronary flow reserve, which could actually be measured by PET imaging. So a lot yet to be learned and to identify. Okay, let's talk a little bit about physiology and anatomy. So we know that we have physiologic tests. We know we have anatomic tests. We talked about this the other day a little bit in terms of calcium scoring and also CT. So, you know, in terms of where we do different tests, calcium scoring is actually the preferred test in people with, who are asymptomatic. Okay, with STRESS-SPECT performed when calcium scores are moderate to severe. Can someone call Dr. Bergler, please, and find out what he needs? Stress MPI is the preferred test in people with known disease. Calcium scoring in people who have a normal MPI, I think, is going to be a very important way of identifying, early disease and maybe treating early disease. Because remember, if you have a normal myocardial perfusion scan, that doesn't mean you don't have coronary artery disease, and that might lead you to underestimating risk. significantly. So we think this is going to be important. And obviously the use of calcium scoring and maybe improving diagnostic accuracy of MPI and SPECT. So I showed you this the other day. Obviously, we perform SPECT after calcium scoring, particularly in the 10% of patients with calcium scores over 400, and also in those with metabolic syndrome where you have a significant increase in risk for coronary artery-related ischemia. This is a nice set of data from EXERRT. This is looking at the value of doing calcium scoring to identify whether someone really should have wrist imaging. Now, that's kind of an interesting concept. And so what you see here is that this is looking at sum stress scores in terms of abnormality. So in people with a sum stress score of 0, which is a normal study, in this study, calcium scoring really didn't help in terms of deciding whether someone needed a rest study. What's also interesting is that in people who had a clearly abnormal myocardial perfusion scan, the calcium score didn't seem to matter either in terms of determining who should have a rest study. But in this larger group that had equivocal findings, okay, a large percentage of these patients did not have to undergo rest imaging because they had a calcium score of 0. And so even though the perfusion study was thought to be abnormal, or equivocally abnormal, and they had no other way of identifying. Now, these people didn't have prone imaging and all that kind of thing, but still, they used calcium scores to help identify in these equivocal nuclear studies who really needed to have further imaging. So this might improve your ability to also do stress-only imaging, recognizing that if someone has a calcium score of 0, even if the scan is mildly abnormal, that's probably a false positive, and they don't need to have any other further testing. This is another study by Dan Berman's group where they looked at a rubidium PET. And it's kind of an interesting study because it looked at the interrelationship between calcium scoring and rubidium PET imaging protocols to identify people with coronary disease, and these people went on to have cath, where 41% had insignificant or normal coronary arteries, 32% had single vessel, 14 double, and 13 triple vessel disease. So let's take a look at this. So if you have a calcium score of 0 and you have a normal PET study, okay, as you go up in calcium score, less and less do you see normal PET studies. Not too surprising there, but you might have patients with kind of small perfusion, ischemic perfusion defects, but you do see a larger number of people with true ischemic perfusion defects. So we recognize that, as I've already shown you. I mean, as you get into higher and higher calcium scores, you're more likely to have myocardial ischemia. So how did they use this to look at obstructive disease in any given vascular territory by PET, combining calcium scoring with PET imaging? So if you have a calcium score of 0, basically none of those arteries that had no calcium had evidence of obstructive disease unless there was clear evidence of ischemia, a fairly large perfusion defect on the PET study, okay? If you look at the calcium score as it gets higher and higher, irrespective of the perfusion results, there was an increase in high-degree stenosis, greater than 50% stenosis. And as you had people with greater than 400 calcium scores, this was even shown even more dramatically in terms of as the PET studies became more and more abnormal, you saw a higher incidence of obstructive disease in individual vessels. So if you look at the ROC curves here, you can see this is looking at the calcium score alone. This is looking at the ischemic perfusion defect, and this is combining ischemia and calcium to increase significantly the ROC curve to 0.85. So again, another way in which combining calcium scoring with another modality, such as a perfusion study, might help you diagnose coronary disease. There's also ways in which we can prognosticate patients by combining all these different modalities. There are many different trials in the literature. These two are from our laboratory, the more recent ones, and then this one by Engbers back in 2016. I showed this the other day. This is looking at people with a normal myocardial perfusion scan who have a low calcium score. Nobody has events. However, if someone has a normal myocardial perfusion scan but a severe calcium score, about 10% have events. This is in a diabetic population. And look over here, if you have ischemia and you have a normal myocardial perfusion scan, you still do well. But if you have ischemia and you have an abnormal myocardial perfusion scan, particularly greater than 1,000, you do very poorly. So there, again, there's this interrelationship between anatomy and physiology in terms of identifying higher risk individuals and lower risk individuals. This is the study by Engber's. This is an interesting study. It's almost 5,000 symptomatic patients with suspected coronary disease. You know, 61-year-old mean age, half for men, half for women, 13% diabetic, all had SPECT and calcium scoring. SPECT was normal in 76%. The calcium score was 0 in 27%. Median follow-up was 2.5 years. 75% out to about 3.8 years. They looked at different MACE, all-cause mortality, non-fatal MI, and revascularization for an annualized event rate of 2.3. This is looking at calcium scoring versus abnormality on SPECT. Okay, so just as many have shown, as you go from a 0 to a high calcium score, you're much more likely to see abnormal myocardial perfusion results. This is looking at the interrelationship in terms of annualized event rates in people based on calcium scoring and SPECT results. So here you see that if you have a calcium score of 0, irrespective of your SPECT results, you do well. But as the calcium score goes up, notice that as you go from a normal SPECT to an abnormal SPECT, your risk increases. Normal, abnormal, normal, abnormal, normal, blue, abnormal, SPECT, red. So even most dramatic as you get into these higher calcium scores. Okay, so there's this interrelationship once you get above 0 in terms of being able to utilize both of these test results to identify who's at lower risk and who's at higher risk. And this is just showing this more in a Kaplan-Meier type curve. This is looking at, you know, people who had this is based on calcium scores. This is normal SPECT, this is abnormal SPECT. So as you go from a calcium score of 0 to 100 versus over 100 versus over 1,000, you can see that risk increases, but that's particularly true if you have an abnormal SPECT. Whereas if you have a calcium score of 0, you do well irrespective. Okay, but with an abnormal SPECT. But if you have anything above that with an abnormal SPECT, you increase your risk of having a cardiac event. So a very nice way of integrating calcium scoring with SPECT results. And in fact, this study, if you look at multivariate analysis, the predictors of events were age for every 10-year change, male gender. Males always get hit with this. I don't know. We're always at higher risk, you know. I don't know what the story is. Okay, calcium score, obviously, as you go up with the calcium score, you get higher risk. And the SPECT results. So as you go from a small to a moderate to a large perfusion defect, risk increases for any degree of calcium except for 0, We have also shown this in our patients without known coronary disease who have a normal SPECT. Calcium score of 0, 0.5% per year, death and MI, total MACE or 0.15% per year death and MI rate. Severe calcium scores are the ones that have events with normal SPECT studies. And the warranty period for a normal SPECT was only 3 years in terms of MACE and was 5 years in terms of death and MI. So again, by integrating, you can identify who has coronary disease maybe early on and be able to treat them so they don't get to this point to begin with. In this study, and in Enger's studies also, it's very important to recognize that people with normal perfusion scans, many of them have abnormal calcium scores. And in fact, many of them have severe scores, like over 20% in this particular study, and also by the study by Engber's. And in our study also, you can see this interrelationship. This is looking at calcium score and annualized event rate for total events and all-cause death and MI. As you go up in calcium score results, you have a higher event rate. But look at from a normal SPECT versus an abnormal SPECT. So the integration of having a high calcium score and an abnormal SPECT increases your risk 3 to 4-fold beyond what you would have with a normal SPECT and a high calcium score. Okay, so identical to the data from Engber's showing the same results in terms of events and death and MI. So again, the integration of these techniques is very helpful. This was also shown. Now, SCOT-HEART was a study, obviously, that used treadmill testing, didn't use myocardial perfusion imaging, but basically showed the same kind of results. Not to go into too much into this trial because it's been talked about a lot, but basically, if you look at hard cardiac events, death and MI, the annualized event rate was 0.94. In the CTA strategy in this study was 0.75. The standard of care is 1.2, which was treadmill testing. The issue with this study was that with treadmill testing, therapy wasn't changed. So people got the same therapy because they didn't know they had coronary disease. They couldn't really tell from the treadmill test results, whereas with CT, they knew they had plaque. So a lot of them got changed in terms of their therapy. And you can see here, 23% randomized to CTA versus 5% randomized to treadmill testing actually had a change in therapy, which were antiplatelet agents, statins, and ACE inhibitors. And therefore, when you look at overall results long-term, after the initial several weeks of treating people with different drugs, you can see the standard of care group did worse than the CTA group. And again, I think this gets back to the idea of why we should integrate techniques, because a normal SPECT study doesn't mean you're immortal. It means you're immortal for maybe 2 years. And then you're going to start having events if you have a lot of plaque. So why not identify that plaque early and treat that plaque so that you can ultimately become immortal and have no real manifestation of coronary artery disease. Also, we have shown this in the ED in terms of the value of 0. In terms of if you have a calcium score of 0, you have a very low event rate. We compared this to SPECT in this one trial by Nabi several years ago. And it turns out that all the patients with abnormal SPECTs here actually had false positive SPECTs because they had normal left heart caths. And there were only 2 events in patients with a normal calcium score of 0, and both of those were just troponin rises, and both of those patients had a normal SPECT study and had no event in follow-up. And so we finally concluded in this study, and we're going to try to look at this further in the coming next year, that you can safely discharge patients home if they have a calcium score of 0 and selectively target SPECT imaging for those with calcium scores above 0. All right, let's spend the last few minutes talking about different agents. Let's talk about flurpiridaz. We're actually involved in a trial here. Dr. Al-Mullah is going to start this up in June. It's a wonderful study in terms of looking at F18 agent, flurpiridaz, for looking at perfusion. It tends to have a lower radiation exposure than what you even see with SPECT with stress-only imaging. And F18 is actually an ideal agent. Why is that? First of all, it has a long half-life compared to rubidium. Why is that important? Because that means you can do exercise. Up until now, with PET imaging, all you can do is pharmacologic stress. With rubidium, with flurpiridaz, because it has a long half-life, you can actually do exercise and then image the patient after the exercise is performed. What about this? The positron range. The positron range for rubidium is very, very long, whereas the positron range for flurpiridaz is very short. Why is that? Because flurpiridaz, I should say flurpiridaz has lower energy, okay? So it's stopped quicker, whereas rubidium has very high energy, and therefore it can travel further before it's annihilated, okay? And therefore, flurpiridaz has the highest spatial resolution, and rubidium has the lowest spatial resolution. So that's another plus for flurpiridaz. And the other thing is, if you look at this issue of spatial resolution, you can see this is rubidium. This is a point source. Look at the difference in spatial resolution between rubidium and flurpiridaz, okay? So anytime you can get better spatial resolution, you're gonna have better results. The other thing is that the extraction fraction is much, much better with flurpiridaz as compared to rubidium. Rubidium is no better than the technetium agents. So why is that important? Well, we know that's important because if you're looking at disparity in flow between normal regions and abnormal regions, if you have rollover at high flows, that means you haven't maximized your counts in the normal regions, which means that you are less likely to see a disparity between flow in normal and abnormal regions, okay? The most beautiful agent is O15 water. If you look at tracer uptake versus blood flow, it's linear, okay? Flurpiridaz is right with O15 water. N13 ammonia is here, rubidium is here, as well as all other technetium tracers. So think about it this way in terms of looking at perfusion defect size. What you see is what you get. If you have normal flow of 2.4 here, you get normal flow, you get tracer uptake consistent with that in terms of counts, 2.4. And if you have a perfusion abnormality where it only increases flow in the abnormal area to 1.8, you can be able to see that very nicely in terms of that disparity. Okay? So that's a 25% reduction. What about if you're here on the curve? Okay, now this 2.4 is only going to be around 2, okay? And this 1.8 is going to be about 1.7. So what you're going to see is you're going to see only a 20% change instead of a 25. And then let's take it a step further. Let's look at rubidium and tech agents. Now, 1.8 is going to be lower here as well as 2.4 here, and now you're going to see less of a disparity between normal areas and abnormal areas because of this rollover along the curve. And now you're going to be even less likely to estimate the true size of any perfusion defect or a perfusion defect you see. So the bottom line is that that by maximizing coronary flow along the linear typical myocardial blood flow you see with stress, you're going to be able to maximize your actual perfusion defect size, which is what we don't do now. But hopefully we'll be able to do that better when we get this agent, and it's in its second phase 3 study. Now, its first phase 3 study showed improved sensitivity, and that was probably because of that ability to detect differences in flow between normal and abnormal regions. Specificity was non-inferior to SPECT imaging. And image quality was better with flurpiridaz compared to SPECT imaging. And if you look at ROC curves, you can see that this is SPECT imaging, and this is PET imaging with flurpiridaz. The ROC curve was improved with flurpiridaz in the total population, and particularly in the obese population, okay? So we're gonna wait and see what happens in the second phase 3 study. That's still coming down the pike, but I think this is gonna be a very important added modality to what we do in the future. You also heard Dr. Almallah talk about sarcoid. I'm not going to spend a lot of time going this, except that remember that when we do sarcoid imaging, we suppress F18 uptake into the heart because we want to see it actually go into the heart because there's sarcoid there, not because the myocardium is starving for glucose. Okay, so we do actually a complete reversal of what we do with viability imaging. But the bottom line is that we can look at different patterns of uptake in terms of looking at perfusion and FTG uptake, and looking at where we see actually uptake, but also uptake here on the FTG, which indicates really a very active form of sarcoid versus burned out, as you can see here. And actually, Ron Blankstein has published some data looking at this, particularly looking actually at sarcoid and the effects in terms of death and MI. And you can see this is normal perfusion and normal FTG, and this is abnormal perfusion or abnormal FTG, and this is abnormal both. And you can see there's an increased risk in mortality as you go to abnormal perfusion with particularly a burned out myocardium with sarcoidosis. So again, we're learning more and more about this as well. Moaz also talked to you about this. I'm not going to spend a lot of time on this in terms of devices, in terms of looking for pacer infections, as well as for looking at things like endocarditis. And finally, PYP, which actually is becoming an interesting way of identifying ATTR amyloid, looking at different uptake and using a cutoff of 1.5. Which at least in the early preliminary data showed very high sensitivity and specificity with an area under the curve of 0.992. We really need to look, we're gonna look at our own data. We now have like over 100 patients who have had amyloid studies and also biopsies, and we'll be looking at this more in depth in terms of where that fits. But I think this is gonna be an important way of addressing the whole issue of amyloid and identifying it appropriately. This is just one example of another patient who you can see the high uptake here and the low uptake for a ratio of 1.6. And this patient also was considered to have amyloid by echocardiography. So nuclear cardiology has a lot of different applications. I think some of them are really going to be important in terms of looking at integration of other techniques, other modalities, as well as the tremendous potential with PET, not only in terms of some of the later things we talk about in terms of sarcoid and such, but also particularly in looking at disease states and the value of looking at coronary flow reserve in terms of identifying patients at risk, diastolic dysfunction, patients who have diabetes, and how we might best intervene in those patients to extend life and improve outcome. Thanks very much. Okay, so that's your whirlwind tour. So any questions?
John, very nice talk. So I noticed the PYP data is really based on a 45 patient study.
Very small population, right.
So the question, I guess, is there's not been any larger studies that have validated that, or has our experience been consistent with?
Well, we've been collecting patients for the last year. I think we have about 100 now who have actual PYP data as well as biopsy data. So we're going to be looking at this more categorically.
Yeah, because I think it's going to be important to have some kind of.
Yeah, it has to be. You can't go by. I mean, this is the study that everyone talks about in the literature. There are other smaller little studies, but this is the one that everyone talks about. There really needs to be more more data in the literature. Yeah. Yeah, man.
The specificity of F18. Why is it the specificity of the F18?
You know, that's you are really astute.
No, we discussed it before.
Man, I can't believe how you brought that up. Did you get that on your own? Huh? Okay. So yeah, I mean, you would expect sensitivity to improve, right? Because what I talked to you about coronary flow reserve, if you're really able to look at flow along entire flows, all the spectrum of flow, you should be able to see disparities in normal areas and abnormal areas much better. So you would anticipate that the size of the perfusion defect would improve in terms of the actual size, and you'd also anticipate that sensitivity would improve, right? But yeah, what about the specificity thing? What about that? And that has always been very curious to me too, because, those studies were not read with prone image. Those SPECT studies were not read with prone imaging. They were not using AC. They were just simply read in terms of, normal or abnormal. And still the specificity was comparable. It was not inferior, but it wasn't better. You have any thoughts about that, Muaz? I mean, it's really kind of a funny circumstance.
It's not very clear, and that's one of the reasons they're doing the second phase. This is one of the reasons they're doing the second phase 3 trial, because the specificity issue.
Okay, and one of the problems with the way they design these studies, okay, is another problem, because if you design a study with the idea that, if you design a study where everyone gets cath, that's one thing. But if you cherry pick people in terms of who you cath based on perfusion results, okay, you're going to bias yourself into a lower specificity, okay? You can't avoid it. You can't avoid it. That was actually shown many years ago with the dipridamol data, that all of a sudden specificity went totally to hell because they were only cathing people that were abnormal, and therefore many of those people just had false positive results, and of course they were normal. So this is one of the problems, I think, with the first study, in that not everyone was undergoing coronary angiography, and therefore, specificity was lower in both fluoropyridaz and SPECT groups, and comparable because it was more of an issue of selection bias than it was in terms of imaging differences. Yeah.
So the new trial, everybody is getting.
Everybody's getting cath. And the other important thing about the new trial is that they are actually enrolling people based on abnormal findings or who are not abnormal by SPECT. In other words, they'd rather have all the people have treadmill tests, okay, that get them into the trial. And then they have a dedicated SPECT fluoropyridaz study and a dedicated dedicated PET fluoropyridaz study and a dedicated technetium SPECT study. Because if you use the technique that you're comparing the PET study with to get the patient in the trial, you can see that causes a tremendous referral bias in terms of the people you get in, right? So actually that is, in fact, when I first met with GE about this, they said, look, you are going to try to get people in because of an abnormal CT or an abnormal treadmill test or abnormal, stress echo. And I said, yes, those are the people we really want to get in. We don't want to put them in because they have an abnormal perfusion scan. Because that's what we're testing, the perfusion results. We don't want to bias it that way, right? So that's probably another reason why the specificity was the way it was in the first pivotal trial. Make sense? Again, that's speculation, but it makes sense from a clinical trialist point of view in terms of why that would be. Any other questions? Okay, well, I'm quitting because I'm tired, so.